All right, welcome back to chapter 24. In this chapter, we're going to primarily focus on hot and cold injuries. So, we're going to talk about thermoregulation, cold injuries, and heat injuries. Your textbook also covers bites and stings, and lightning injuries and altitude injuries, although it is a very small portion of the chapter. So, we will gloss over that. So, talking about thermoregulation. Humans are homeotherms, and as such, we're capable of maintaining a relatively constant body temperature across a wide range of ambient temperatures. So we're able to do this because of both behavioral and physiological processes. An example of behavior would be how we search for and maintain favorable environments. This includes building houses and wearing clothes, stuff like that. An example of physiology would be how our autonomic nervous systems initiate things like shivering in the cold and sweating in the heat. These are things that we don't have a whole lot of control over. They're regulated by our autonomic nervous system. So these thermoregulatory processes are controlled by a negative feedback loop within the body. Thermoreceptors send signals to the hypothalamus, which is a part of the brain, regarding the temperature of the body, and then the hypothalamus sets certain thermoregulatory processes in motion. When temperature changes, there are immediate and important effects on metabolism as well as other physiological mechanisms. So, the normal human body temperature favors the sort of chemical reactions that we see within the body. They favor speed at the expense of tissue resources. So, as our temperature goes up, we see the speed of metabolic processes increase, but the consumption of resources also goes up. Whereas lower temperatures tends to conserve resources, and this is a principle that's used across biology, especially for poikilotherms, which are cold-blooded animals. So, a deviation of about 2 degrees centigrade, which is about 3.5 degrees Fahrenheit, above or below the normal core temperature is usually well tolerated by the various regulatory systems of the body. But once we get outside of that 2 degrees centigrade range, so a discrepancy of 3 degrees or more, begins to disrupt these symptoms. This includes those involved in temperature regulation. So we find that once you drop below a certain temperature, you actually lose the ability to control your temperature. So it just gets worse at that point. At this level of deviation, if there's no intervention, physiological problems compound very quickly. And we'll get into that in just a little bit. So the physical laws that govern heat transfer also determine the net energy flux into and out of the human body. So, a high metabolic rate of heat production is generally critical for maintaining a constant body temperature in mammals. Heat transfer between objects that are in direct contact is called conduction. The direction of heat flow is always from the higher source of heat to the lower temperature. Because conduction involves a direct interaction between molecules, this type of heat transfer is usually minimal except under certain circumstances, such as, for example, sitting on a cold rock with little insulation, as we see here. Under these conditions, the heat lost to the rock would be similar to that lost from the remainder of the body's surface by radiation and convection. Adequate insulation should be placed under patients who are in direct contact with hot or cold substrates. This is one of the reasons why backboards were so problematic, and we got rid of backboards a few years back, is that we would see traumatized patients continue to lose heat into this cold plastic. So that's an example. Muscle tissue has about twice the conductivity of fat tissue, meaning that fat is more insulating. So someone with a lower BMI will tend to lose heat energy faster than someone with a high BMI. And then water has about 25 times the conductivity of air. So this is why we see patients get really cold if they are immersed in water, things like that. Convection can be seen as the facilitation of conduction caused by the movement of molecules in a gas or a liquid. So, under relatively neutral conditions, about 40% of heat loss from a nude human is mediated by convection. So, increases in air or fluid velocity greatly increases convective heat transfer. For example, if you were to wet someone and then fan them minimally, the you will greatly augment the heat loss in a cool environment. And we'll see this come into play when we talk about the treatment for heat injuries. So adding a little bit of water and then blowing some air over them will cause this convective cooling. All objects at temperatures of more than absolute zero emit electromagnetic radiation. So this energy transfer occurs through space and doesn't require any intervening medium. So the other methods of heat loss require that something carry the heat away. With radiation, nothing needs to carry the heat away. You merely release heat energy through infrared radiation. In any given situation, the object is both transmitting and receiving IR thermal radiation. So if if there's any source of light, you are receiving some level of thermal radiation, and you are constantly giving off thermal radiation. So this radiant heat loss accounts for about 45% of the total heat loss of the body. All right, so when water changes state, we know that a large amount of energy is either absorbed or given off. So when water turns to ice, we know that a large amount of energy is given off, and we know that when water changes to gas, it requires the absorption of a large amount of energy. So evaporation, the evaporation of 1 gram of water at 35 degrees centigrade, or about 95 degrees Fahrenheit, which is the usual skin temperature of a person who is sweating, requires the input of about 0.5 kilocalories of thermal energy, a little bit more than 0.5 kilocalories. In the field, the preferred cooling measure is, again, to mist or splash water on the patient, and then coupled with air fanning. So not only are we providing a convective air current, but the evaporation of that fluid from the skin is actually what's going to carry away a majority of that heat energy. Heat absorbed by the evaporation of 100 cc's of water will lower the body temperature by about 1 degree centigrade. And we're going to get into exactly where the body falls on this thermometer and how many degrees centigrade we have to cool someone or heat someone up by in just a little bit. But 100 cc's of water will generally, when evaporated, cool about 1 degree centigrade. In a neutral thermal environment, active thermoregulatory sweating does not occur. So as we're all sitting here in our relatively comfortable environments, chances are you're not sweating profusely. And evaporation, because of that, evaporation only accounts for about 15% of the total heat loss in a given day. And of this, slightly more than half is the result of evaporation from the respiratory tract, with the remainder coming from water that sort of passively diffuses through skin and evaporates. So this is referred in medicine as insensible losses. And, this is one of the reasons why, even if you're not working out heavily or sweating heavily, you still need to drink 8 tall glasses of water any given day, which is about a liter of water. So let's talk about hypothermia. Hypothermia is most often accidental and is usually a secondary complication of other processes such as trauma or sepsis. Hypothermia occurs in various locations and in all seasons, so don't think that this is confined to snowy, cold environments in the winter. The urban setting accounts for the majority of cases in industrialized countries. And we'll talk specifically about urban hypothermia in a bit, but this is not the wilderness setting that we think of when we think of hypothermia. So let's talk about some of the pathophysiology. Cold depresses your central nervous system. So because of this, we see a resulting impaired memory and judgment, slurred speech, and decreased consciousness. During cold weather expeditions, leaders are prone to impaired judgment, perhaps risk-taking behavior, and because of that, we'll see people who are cold get themselves into traumatic situations, thus compounding their injuries. What's happening inside? Neurons are initially stimulated by slight decreases in temperature. However, as the brain cools, there's actually a linear decline in cerebral metabolism. And so we can use this to our benefit. So we use therapeutic hypothermia, or what's called targeted temperature management, to afford cerebral protection following cardiac arrest because of this decreased cerebral metabolic requirement for oxygen. So immediately after getting ROSC on a cardiac arrest, what we see hospitals do is applying pads to cool the body down to about 33 degrees centigrade. The other thing that we see is that cold depresses the cardiovascular system. And so again, cold stress initially increases the consumption of myocardial oxygen, and the autonomic nervous system stimulation causes this sort of reflex tachycardia and peripheral vasoconstriction, both of which increase your systemic blood pressure and cardiac afterload. So because it's cold out, we constrict our peripheral blood vessels. This brings more blood close to the core. It also increases your systemic vascular resistance. And we remember all the way back in some of the first weeks when we talked about how blood pressure is cardiac output times systemic vascular resistance. So we can see that initially this cold stress is going to put a little bit more strain on our cardiovascular system. But after the initial shock, as core temperature drops, there's usually a fairly linear decrease in heart rate. Because this bradycardia is the result of decreased spontaneous depolarization of cardiac pacemaker cells, it's not something that you're going to correct with medication. So you'll see someone with a really slow heart rate when they're very, very cold. This is not something that you can call a paramedic up for and they can just, push some medicine to make their heart rate faster. It's because the conductive cells in the heart just are not responding as fast as they used to. And then this cold-induced change causes changes in pH. We know that pH affects oxygen saturation. There's going to be electrolytic imbalances, and we see sugar is often altered by this. Insulin doesn't work in cold environments. And so all of this is also going to alter the electrical conduction of the heart and will, in general, make the heart very, very fragile to shocks. So someone who's very cold has a much lower threshold of going into a lethal arrhythmia. And so let's actually take a look at these temperatures here. So the stages of hypothermia are broadly categorized as mild, moderate, and severe. And then I've also added this profound hypothermia down here at the bottom, and we'll talk a little bit about that. So mild hypothermia, we know that 37 degrees centigrade, or about 98.6 degrees Fahrenheit, plus or minus a degree, is your normal oral temperature. Now, when you take a core temperature, that's either through an artery or down the esophagus or up into the rectum, these core temperatures tend to be slightly higher than your normal oral temperature. But overwhelmingly, we're either taking an oral temperature or some other type of temperature. Keep in mind when you're taking temperature, things like tympanic thermometers, infrared thermometers, like the ones that they use to scan your forehead, the ones they stick in your ear, putting a thermometer in the armpit, these can all give you a general ballpark of your body temperature, but are wildly inaccurate and wildly variable. And so these are not something that we would rely on for medicine. So we're talking about either oral temperatures or core temperatures. So when we drop down to around 34 degrees centigrade, we see the development of this amnesia, these dysarthrias and poor judgment, maladaptive behavior. So one of the things we'll see is this paradoxical undressing as you get colder and colder, where someone who's very cold will begin to undress. And this is usually later on in the decrease of body temperature. We see these people, they have normal blood pressures. they're breathing normally. We may see slight tachycardia, and then when they get colder, progressive bradycardia. And around 33 degrees centigrade, remember this is the temperature that we use for targeted temperature management following cardiac arrest, we see the development of ataxia and apathy. Ataxia is sort of the inability to walk. This is the mumbles, the stumbles, and the fumbles is what it's known as when we teach it in wilderness medicine. So we see ataxia, apathy, linear depression of cerebral metabolism, tachypnea, and then progressive decrease in respiratory minute volume. So just like the heart rate, it'll initially go up and then it will go down quite a bit and you'll start breathing a lot slower. This is also around the time we see what's called cold diuresis. Now, if you've ever gotten bundled up to go outside, and then as soon as you step outside, you realize you have to pee, that's not because you forgot to go when you were inside. It's because the cold hit you and initiated cold diuresis. If you just hold it, you can usually get past that feeling initially, but we see it come back as you get colder. Under moderate hypothermia, we see it starting at around 32 degrees centigrade, which is around 89.6 degrees Fahrenheit. This is where we start to see stupor, and we see that the body has about a 25% decrease in total oxygen consumption. As we get colder, around 31 degrees centigrade, we see that the shivering response that was initiated when we were slightly cold goes away. So you'll actually get too cold to shiver at some point, and that point is around 31 degrees centigrade. As we continue down, 30 degrees centigrade, which is about 86 degrees Fahrenheit, this is where we see the development of cardiac conduction abnormalities. So we'll see the development of atrial fibrillation and other strange conduction abnormalities that we can see in an EKG. This is also the point, sort of at the borderline between moderate and severe. This is the point where we see a dysfunction in the body's ability to generate heat. So we've already extinguished the shivering response, and now we're going to start becoming poikilothermic. And again, if you remember from biology, poikilothermia is basically cold-blooded. You assume whatever the temperature is around you because you don't have any active positive thermoregulatory mechanisms. And so because of all the things we've talked about, cardiac output drops to about 2/3 of what was normal. And this is also the temperature that we see insulin begin to be ineffective. So at the bottom side of moderate, this is really where we see a massive dysfunction in a lot of the biochemical systems of the body. Once we enter into severe hypothermia, this is 28 degrees centigrade and down to about 24 degrees centigrade. This is where we see the decreased threshold for ventricular fibrillation. And ventricular fibrillation, if you remember from the cardiology section, this is where the heart no longer beats as a unit. It doesn't beat to force blood out of the heart. It's actually just quivering. And this is a lethal rhythm because your cardiac output essentially drops to zero. We also see a loss of reflexes and voluntary motion. If the person is still awake at this point, they're not going to be responsive to a lot of the deep reflexes that we would expect. And then down here in profound hypothermia, we see that it starts around 24 degrees. At 24 degrees, we see significant hypotension and bradycardia. Most people are not awake at this point. At around 18 degrees, we see asystole. This is just the pause of the heart. There's no longer any cardiac motion whatsoever. 13.7 degrees centigrade is the lowest adult accidental hypothermia survival recorded. And it's actually a little bit lower a little bit higher for infants. So the lowest infant hypothermia survival was recorded at around 15 degrees centigrade. But still, that is really, really cold. That is in the mid to upper 50s Fahrenheit. And then the lowest therapeutic hypothermia survival, this is some kind of induced hypothermia. The coldest temperature that we've ever gotten someone back from was 9 degrees centigrade, which is about 48.2 degrees Fahrenheit. Now, what I want you to sort of take away from this is that all of these temperatures are well above freezing. All right, all of these temperatures that we're dealing with are generally between 100 degrees Fahrenheit and 80 degrees Fahrenheit. So a very narrow window of effective life for human beings. So let's talk about some factors that predispose you to hypothermia. And I've grouped these into three general categories: decreased heat production, increased heat loss, and then in the middle of there, a failure of your thermoregulatory systems. So under decreased heat production, we see that there are some endocrine problems. For example, hypothyroidism, certain types of diabetes. These lead to just an overall decreased generation of heat within the body. A calorie deficit, this, you can also think of this as insufficient fuel. And this is things we've talked about before: hypoglycemia, malnutrition, so you're just not eating the right types of things. Especially if you are in wilderness medicine, you see someone who's been lost for several days or several weeks. They could have significant malnutrition, which would lead to a calorie deficit. And then extreme physical exertion. And so we see this with extreme sports people. For example, if you're going to walk from Alaska to Greenland across the top of Canada, dragging a sled behind you, we see that that's going to require an extreme level of exertion. And indeed, when we take these people's blood sugar, we see that they are much lower than what we would consider physiologically normal. And so these that decreased heat production sort of predisposes you to hypothermia. Lack of exertion. So neuromuscular physical exertion is one of our thermoregulatory mechanisms. So we can shiver, we can jump around, clap our hands, things like that. And so anything that limits the physical exertion, such as extremes of age, anything that impairs your shivering, inactivity, or lack of adaptation, these are going to decrease your heat production. So when we're talking about impaired thermoregulation, the failure of the peripheral nervous system, these are things like neuropathies, spinal cord injuries, diabetes, anything that prevents your body from initially detecting the cold signals coming from the environment. Those are not going to trigger your hypothalamus to initiate those thermoregulatory mechanisms. We also see central nervous system failure. This is a dysfunction of the brain tissue, the hypothalamus itself, either from trauma or cancers, or really anything that's going to affect the brain can affect the central nervous system failure. There's not really a lot that we're going to do about that. And then skin failure. So a big part of our thermoregulatory system is our skin. And so if that is either removed, for example, with burns, or otherwise impaired, then we lose some of the thermoregulatory function of the skin. And then increased heat loss. So environmental factors include the ambient temperature, the wind chill, the relative humidity, the length of time that we are exposed to that. So when you hear someone dying of exposure, this is bad environmental conditions multiplied by the length of time that they were exposed to those conditions. And this has a lot to do, obviously, with your clothing and other sorts of shelter that you find or make. We talk about drugs. We're talking about induced vasodilation. And so we briefly mentioned the effects of alcohol, and we'll talk about it a little bit more later. But drugs, poisons, alcohols, these may all cause peripheral vasodilation, which will bring more blood to the surface of the skin and make you feel warm, but will ultimately speed the cooling of your body, which is not a great way to survive. This next one, iatrogenic. So genic means the cause of, and when we put iatro in front of that the root word of that is provider or healer or doctor. And so iatrogenic, anything that is iatrogenic, is caused by the provider. It's caused by us, or caused by the treatment of some other injury or illness. So one of the biggest sources of iatrogenic cooling is a trauma patient who we strip this person and make them naked in order to assess for their injuries. However, the other side of that is that we've just stripped away all their insulation and now they're getting cold. Other examples of this are emergency childbirth. If a paramedic starts an IV infusion of something and doesn't heat that fluid, they'll get very cold. And if you've ever been in an emergency room and received an infusion of normal saline or something like that, you'll know that it cools you off quite quickly. And then there are other sources. So, for example, we talked about trauma. Infections is a not uncommon source of hypothermia, especially septic shock. We see other things like pancreatitis, cardiopulmonary disease, vascular insufficiency. These are all sorts of other causes that increases your rate of heat loss. So all of these will predispose you to hypothermia. And to sort of send this home, let's talk a little bit about urban hypothermia. So hypothermia can be a serious problem in big cities, especially in the homeless and the elderly populations. These populations tend to have a variety of comorbid factors that predispose them to accidental hypothermia. Alcohol intoxication, which we just talked about, although providing the sensation of warmth via this peripheral vasodilation, contributes to rapid cooling, which is increased heat loss, and a blunting of the thermoregulatory mechanisms, which is a thermoregulatory failure. Another concerning trend is elderly folks having heating available in their homes but not using it for fear of cost. Urban hypothermia can occur indoors, and one need look no further than Texas and other parts of the southern United States this last month, where we had people dying inside their homes because of a failure to heat them. And so, this is obviously a concerning problem, especially so here in the Northeast. So once again, this is going back to week 1. We have to look to the social determinants of health to find the underlying causes of the immediate condition. So while we need to treat for these immediate life threats, we should also be putting our public health hats on and connecting these patients with non-medical resources that they'll need to prevent future medical calls. And so in the case of the elderly folks who have economic instability because of the high cost of their health care or insufficient payment through Social Security, we're talking about the variety of problems that are associated with homelessness, including psychiatric disturbances and a lack of social support for those conditions. There's a lot that we can address there that may not at first glance seem to have much to do with their immediate life threats, but by addressing them, we can prevent future medical calls and we can prevent future morbidity for these folks. All right, and I just want to touch on frostbite before we dig into specific treatments for hypothermia. Frostbite is a true freezing injury. So your book discusses some non-freezing injuries, for example, trench foot, and these are injuries caused to the tissue without the actual physical change of state of water. However, that is not the case with frostbite. Frostbite is a true freezing injuries, and depending on the severity, ice crystals will tend to form deep in the tissues, either in the superficial tissues or deeper tissues, and we'll talk a little bit about the degrees of frostbite here. The degree of injury is a complex interaction of many factors, including environmental, temperature, wind chill, length of exposure, altitude, things that we talked about, and individual factors like genetics, comorbidities, any medication or drugs you may have taken, clothing, skin products, previous injuries. And regardless of the classification scheme that you use, the people who study this tend to agree that the changes are caused by direct injury, and that's extracellular ice formation, then intracellular ice formation, cell dehydration and shrinkage, abnormal intracellular electrolyte concentrations, and then a denaturation of lipid protein complexes. And so to put this all in more simple terms, if you've ever put a can of soda in the freezer and then forgotten about it, When you come back, that can is generally exploded. So the can will have torn open, and while the liquid inside may not have spilled out, it may still be frozen and not make a mess. When you take that can and you put it on the counter to thaw, you come back a little while later and there's just a pool of water there. Think of frostbite the same way. The cell is a closed container of fluid, and when you freeze it, it will tend to expand and rupture. And when you thaw it, we see that that rupture leads to significant edema and potentially blistering and other diseases of the tissue. And in any case, that cell is dead, and the cells next to it are also dead if they're frozen. So we see additionally tissue necrosis and other complications. So across the screen here, we have the various degrees of frostbite. And you'll notice that this is a lot like burn injuries. And the type of tissue destruction and the type of signs and symptoms that we see are also sort of similar to how we classify burns. So not pictured on the screen is something called frost nip. Frost nip is superficial and is associated with intense vasoconstriction. So this is not actually a freezing injury, but it's often grouped in with frostbite. It's characterized by discomfort in the involved parts, but is generally self-resolving, self-limiting. All you have to do is warm up the exposed area and everything is fine. We get into first degree frostbite, and these injuries show numbness and erythema. Erythema, again, refers to redness in the skin. There may be initially a firm white or yellow plaque in the area of injury, and there's generally no tissue loss, although edema is common. When we move over to second degree injury, this results in superficial skin vesiculation, and a vesicle is a blister. So it's just a bubble of skin filled with fluid. And this fluid will be clear or potentially milky, and then it'll be surrounded by erythema and edema. And so we see the tip of this person's finger. I don't know if his gloves were worn out or had insufficient insulation, but we see that there's a nice little blister at the tip of his pinky finger there. Third degree injury shows deeper blisters, and these are sometimes characterized by purple blood-containing fluid, right? So we see the extent of the blisters on this person's hand under third degree, much larger blisters, much purple blisters, blood vessels are involved here, leaking blood into these fluid cavities, and there's usually some pretty extensive tissue damage and loss here. They may or may not lose the fingers along with this. You can get third degree frostbite and not lose your fingers, but you can also get third degree frostbite and lose fingernails, lose parts of fingers. So it really depends on the extent of the injury. And then we have fourth degree, and it says partial thickness there, and that is incorrect. It is more than full thickness. So fourth degree injury is completely through the dermis and involves relatively avascular subcuticular tissues. And so this is all the way through the dermis into the muscle, and we can see in the picture over there that actually I have a caption for each one of these pictures. So classically, frostbite has been described by its clinical presentation, but it's difficult to predict in the field and before rewarming. So in this first picture here, we see a Nordic skier with first degree frostbite. This skier reported having skied for about 90 minutes in negative 10 degree Fahrenheit temperature, and then he was just unaware that his shirt underneath a parka had come untucked from his trousers. So this is just basically from his shirt coming untucked in very cold environment. The second picture is the second degree frostbite of the pinky finger after several seconds exposure to negative 50 wind chill when the gloves were briefly removed to handle the placement of a carabiner to a fixed rope. So he took his glove off just long enough to clip a carabiner in, and then he put his glove back on. And because it was a negative 50 degree wind chill where he was, that caused a rapid freezing of the tissues. This third picture is a climber with second, third, and fourth degree frostbite of the hands. Note that the first four fingers there, not the thumb, but the actual the fingers, with hemorrhagic bulla over the areas of the third degree injury. So how can you tell they're hemorrhagic blisters? Because they're purple. And then the clear blisters over the dorsum of the hand. So we see those yellowish serous fluid filled blisters over the back of the hand there. And then the unblistered fourth degree injury of the thumb. So we see that there's no blisters, but we see it has sort of that dusky appearance, and that's not a good thing. That is likely indicative that he will be thumbless in the near future. And then finally, the fourth degree. This is a climber with a fourth degree severe frostbite injury just hours after rewarming. There's no blisters. The fingers have no sensation, and capillary refill is completely absent. And then the picture right below that is an 8-week follow-up of that hand with a complete mummification and auto amputation of the remaining digits. So, there has been some medical and surgical intervention generally in these cases, but this person's fingers literally froze and fell off. So, definitely not a optimal outcome. So in general, for frostbite, our treatment goals, and I don't believe the state of New Hampshire has a frostbite protocol per se, because it is a relatively rare occurrence. So the places you get frostbite here in New Hampshire is you'd either have to be really drunk or you'd have to be climbing Mount Washington or something similar. And so we see it's a relatively rare occurrence outside the wilderness environment, but not impossible. So our treatment goals, we want to rewarm the affected area, and once warm, we have to keep it warm. So the problem here is if we refreeze a thawed extremity, it's going to cause significantly greater tissue damage. So it's actually better to keep the area frozen until you reach a stable environment than, for example, light a fire, rewarm the toes, and then have them freeze back in someone's boot. And just to bring back the can analogy, you're not going to get the soda back in the can if you defrost the can on the counter and then freeze your entire kitchen. You're just going to make a bigger mess. We also see, as in these pictures, we see that the skin is going to swell significantly once rewarming is initiated, and this is true regardless of the degree of the frostbite. Especially so in higher degrees of frostbite. And so we want to remove constricting items like rings, bracelets, other jewelry. Keep in mind, though, that if you're wearing jewelry in a cold environment, this will generally be a greater conductor of cold and will likely be the initiation point for a lot of these cold injuries if you're wearing metal jewelry. And then for all of these, we need to expect and treat for significant pain. We're going to address these in a similar fashion as burns, and so that involves a dry, sterile dressing. And we also want to wrap between fingers and toes so they don't get stuck together. And we'll talk more about burns later on in the course. So assessment and treatment for hypothermia. It's a pretty extensive protocol in the New Hampshire protocol book. And so it goes on for an entire page, and all of this is at the EMT level. So all of our care, short of a few things that can be done by a paramedic, are going to be done at the EMT level. So we start off with these routine patient care. We're always going to treat for our ABCs first. And remember that we're handling these people gently because they have a very low threshold of ventricular fibrillation. We want to prevent the thing that is killing them. We want to stop the process that they are dying from, which in this case is heat loss. So if we're outside, we're going to insulate them from the ground. We're going to try to shield them from wind and weather. We're going to try to get them into a warm environment. Hopefully this is the back of your ambulance, but if not, if you're in a wilderness setting, then you're going to try to, heat the environment that you're in. We're going to remove wet clothing. We're going to dry the patient as much as possible and replace their clothing with dry insulating clothing. We're going to try to cover them with warm blankets, including their head and neck. Don't forget the head. A lot of commercially manufactured hypothermia management kits will actually come with a foil head wrap specifically for the very vascular skin of your head. And then we're going to use active warming measures for the trunk. So whether this is something like a ready heat blanket, which is effectively just a big hand warmer, or hot water in hot water bottles, or warm IV fluids, or other heat packs, we're gonna press those against the trunk, up into the armpits, the necks, the groin, and we're going to try to actively rewarm them, and especially if they are too cold to generate their own heat. Then we're going to use all of our knowledge and potentially a reference sheet to classify the hypothermia clinically based on their vital signs, their level of consciousness, and the intensity of shivering. Remember that shivering will stop if they get cold enough. We're then going to do a little bit of diagnostic data collection. So we're going to obtain a core temperature. And a core temperature for a hypothermic person is really important. If you insert the thermometer into their mouth, you may not get an accurate reading, and the interventions that you use may be misguided. So it's important to get a core temperature. And this is, for all intents and purposes, for our setting, this is going to be a rectal temperature. So make sure that you are using your temperature probes, probe covers. You're going to insert this about 11 centimeters or about 5 inches into the rectum in order to get an accurate reading. We're also going to obtain a blood glucose reading. So again, we know that being very cold affects various biochemical systems in the body, and one of those is the use of insulin to transport glucose into the cells. And so by getting a blood glucose reading, we can get a general picture of what's going on with this person metabolically, and either rule out insufficient fuel as a cause of hypothermia, or rule in the need for other treatments. So we're going to support shivering with calorie replacement if alert. So if someone asks you what's more important, giving them a warm beverage or giving them a sweet beverage, the answer is giving them a sweet beverage. The heat from the fluid that they're drinking is going to do minimal amounts of warming once inside their body. The body is going to cool off that fluid relatively rapidly. However, giving them the fuel that they need to start shivering and putting into motion these metabolic processes of heat production is going to have a far greater reward or far greater payback. If we find someone who is not breathing and doesn't seem to have a pulse, right, we want to measure their respiration pulse for a minimum of 60 seconds. And remember, going back to when we did CPR, we have to measure it for a minimum of 10 seconds, just so that we can catch one of those breaths if they're breathing very slowly. Well, we're going to measure for an entire minute to assess the rate of their respiration and heart rate, because they may be profoundly bradycardic and profoundly slow in their breathing. So if we see that their pulse and their breathing are absent, well, then generally we'd want to start CPR. However, there are a few contraindications here that are specific to hypothermic patients. So obvious signs of irreversible death. So if they were dead and then they got cold, no amount of rewarming and no amount of CPR is going to bring them back to life because they were already dead before they got cold. If they are so frozen that you cannot press their chest wall in for CPR, if they are just a solid block of human, CPR is not going to be effective. It's just going to waste your energy. Avalanche burial for greater than 35 minutes with an airway packed full of snow. So if you're buried in an avalanche and you survive and you have, an air pocket to breathe in and things like that, we find that when we take these people out, they are significantly hypothermic. However, they are still salvageable. But what we find is that if their airway was packed with snow as a process of being swept up by the avalanche, that our chances of saving them are significantly less. And then finally, If you are providing CPR and you become exhausted by the effort, or if you find that the environment is dangerous to remain in. So, for example, you're in an avalanche field and you're doing CPR. If you're in danger of a second avalanche, for example, or if weather conditions, for example, on the top of Mount Washington, where it's blowing 105 miles an hour and it's 72 below zero, this is going to present a danger to you, especially when we consider that the positive outcomes from CPR, especially in the wilderness, are very, very minimal. Hypothermic patients without contraindications to CPR will have continuous CPR performed until they reach criteria until they're warm. So the saying in hypothermia, or saying in EMS, is that no one's dead until they're warm and dead, and this is especially true in hypothermia. So where generally we have a set of guidelines for the termination of resuscitation, those guidelines do not apply to patients whose core temperature is still below 32 degrees centigrade. And then the rest of the protocol sort of goes into cardiac instability because of that lower threshold of ventricular fibrillation. And then also, one of the things that we have available to us here in the state of New Hampshire is an extracorporeal membranous oxygenation, or ECMO, center. So if we get these patients, potentially via helicopter, over to Dartmouth Hitchcock, these people can be put on cardiopulmonary bypass, where a machine takes the blood out of their body, oxygenates it, and then puts it back into the body. So we need to consider these folks for potentially helicopter extraction to the nearest ECMO center. So let's talk about hyperthermia, so too much heat. And so hyperthermia is generally divided into three categories of illness. And these are increasing in severity. So generally, heat cramps, these are brief, painful skeletal muscle spasms. And this generally happens after exertion. So where we see this most often is someone's been outside, they've been working all day, they haven't been eating, they haven't been drinking, and then they go home, they sit down on the couch, they crack open their first beer of the night, and they're suddenly hit by sudden severe muscular cramps and spasms. And they may also have some associated nausea. The reason for these cramps is a loss of electrolytes, and the best treatment is to replenish those electrolytes, usually with a sports drink or something like that. So get that sodium, get the potassium, get the sugar back into your body, and bring those electrolytes back into balance. Now, many people, especially older folks, will remember salt tablets as a remedy to heat cramps. This is not something that we do in modern medicine, so we don't give salt tablets anymore. It's better to drink a relatively balanced electrolyte solution like oral rehydration salts, or something like Gatorade. Next, we have heat exhaustion. This is a mild to moderate illness with inability to sustain cardiac output. And so basically what we see here is that through a process of significant sweating and increased body temperature and dehydration, this person becomes slightly hypovolemic. And because of this, they'll experience a variety of symptoms: nausea, fatigue, dizziness, especially when standing up, general weakness, and a rapid pulse that comes from compensatory mechanisms. And so for someone with heat exhaustion, they may or may not lose consciousness, they may or may not collapse, but when we take their core temperature, it is less than 104 degrees Fahrenheit. And so our solution to this is to move this person, lay them down, move them to a cool, shaded environment. Potentially you could elevate their legs, although this is sort of dubious in terms of its support with evidence. We want to definitely loosen or remove their clothing, actively cool their skin using misting and fanning, and then administer oral fluids if they're awake. So again, seek shade, drink cool fluids, rest, and this person will generally make a good recovery. Heat stroke is a true medical emergency. So this is a profound central nervous system abnormality. And so we see agitation, delirium, stupor, or even coma with heat stroke. And then they have severe hyperthermia. So heat stroke doesn't have anything to do with electrolytes or hypovolemia. Heat stroke is purely about internal core body temperature. And so when someone's body temperature is above 104 degrees Fahrenheit or 40 degrees centigrade, that is heat stroke, and this is a true medical emergency. So the treatment for these folks, we want to make sure they have an open airway. We want to move them to a cool environment. Immediately start cooling them using water bath and continuous fanning. We can use things like ice packs in the groin and axilla, but we find that this is less effective than the whole body cooling and fanning. Some organizations may also use ice sheets, so they'll have a cooler full of ice water, and they'll have sheets in that ice water, and you'll pull these sheets out and drape them across the patient. Those are moderately effective at cooling someone down quickly. And our goal is to restore normal body temperature. So we don't want to turn this person into a popsicle and give them a cold injury as well as a hot injury. We want to return them back to a normal temperature. And by normal temperature, we're talking about, 39 degrees centigrade or about 102 degrees Fahrenheit. We do not want to cool them so much and so fast that they begin shivering, which then defeats the point. And so these people are going to need hospital care. So there's no recovery in the field from heat stroke. We see that these people are at increased risk of neurological deficits, of end organ failure, and so these people need to be transported to the hospital. So let's talk about some predisposing factors for hyperthermia. So environmental factors, we have high ambient temperatures with high humidity, and along with this, a lack of air movement. That's sort of a deadly summer combination, especially for people with impaired thermoregulation, like elderly people. Especially people in the cities where they have lack of trees and shrubberies. These tend to increase exposure to sunlight and thermal radiation from the sun. Folks with lack of access to air conditioning. So if we see summer heat wave associated with rolling brownouts, as we do in some densely populated areas, we see that the air conditioning goes out, and then also disproportionately it's the elderly that are affected by this overheating. Also a lack of shelter. So we see these sorts of conditions with the homeless populations where they're outside all day, especially in an urban situation, and get significantly dehydrated, and then we're called out to man down, altered mental status. Fortunately, Manchester has a lot of parks. And then combine all of this and then extend it for multiple days. So a heat wave is generally considered greater than 3 days of temperatures greater than 90 degrees Fahrenheit. And so we'll talk about in just the next slide how all of this can come together to really sort of hammer on people who are at risk. So individual factors. Age, so especially small children and over adults are at increased risk. If you're obese, because we remember that fat is more thermally insulative than muscle, and so people who are obese are more likely to collect and retain heat. Poor levels of physical fitness, especially cardiovascular health. Lack of acclimatization. So if you go to a hot country, say you go to Mexico for vacation, or you're traveling to, Africa for a humanitarian aid mission, if you're not acclimated to the weather there, coming directly from northern New England, then we find that you're at increased risk for heat-related illnesses. So Especially in travel medicine, we say that you want to spend a couple weeks in your new environment, not um, not doing vigorous exercise and sort of getting used to the the environment there. And then dehydration, always dehydration. So you want to be drinking water um, all the time, but especially when it's hot. Then we see drug use. So we talked about alcohol. Alcohol is a diuretic, but alcohol specifically has some effects in the body that mess with your thermoregulatory mechanisms. Other drugs, anticholinergics like atropine, we talked about that in the pharmacology section. Um, Beta adrenergic blockers. So we talk, certain blood pressure medications, antihistamines, certain drugs like amphetamines, whether it's something that you take for ADD or it's some meth that you got on the street. We see malignant hyperthermia or not malignant hyperthermia, but we see hyperthermia associated with the consumption of these drugs, especially with excited delirium and conditions like that. Antidepressants. So there's a lot of different medications that mess with your ability to thermoregulate. Um, and then finally, compromised health status. So viral infections, inflammation, skin disorders, cardiovascular disease, and diabetes. These are all things that contribute in general, having an altered state of health, which then doesn't allow you to adequately respond to increased temperatures. So this here is the heat index chart, and this is from the National Weather Service, and this is very common, relatively common, especially in outdoor medicine and expeditionary types of medicine, where we're going to be referencing this chart when we make determinations about work rest cycles and how much we're going to do in a given day during an expedition. But let's apply it to right here in Manchester. So we have weather.com gave us a forecast of 95 degrees Fahrenheit, and you see down there the humidity is about 45 degrees. So that doesn't seem too bad. It's a little muggy, but I mean it's not super hot, right? So when we find this on the chart, 45 degrees in terms of humidity and 95 degrees in terms of temperature, that's actually around 102 degrees Fahrenheit that it feels like. That is the heat index chart. And so now we're responding to, an elderly lady living alone, concerned about her electricity bill. She's not running the air conditioning, and it's super hot inside of her house because she hasn't opened any of the windows. And, now we find her on the floor, dehydrated, hyperthermic, right? And so it can very easily happen in our environments and not in, the Saharan desert or, in Cancun on vacation. This is something that can happen in Manchester, New Hampshire. So let's take a look at the assessment and treatment. So again, we always start off with routine patient care. We want to make sure that our ABCs are in place, intact, and that our patient isn't going to die from immediate life threats. And then we're going to stop the thing that's killing the patient. So in this case, we're going to move a patient to a cool area, and we're going to shield them from exposure to the sun and other heat sources. We're going to remove excess clothing and loosen restrictive garments. If alert and able, we're going to give this person sips of cool fluid. And this, you may recall, looks a lot like the treatment for heat exhaustion. And then we're going to obtain a core temperature. And so, again, a core temperature, in our setting, a core temperature is going to be a rectal temperature. So you're going to have this person roll over on their side, pull their pants down. You're going to apply a little bit of surgical lubricant to the thermometer cover. And again, about 5 inches or 11 centimeters into the rectum. And then we're going to wait for a temperature. Now, this should be done with a calibrated rectal thermometer. Otherwise, your readings are going to be slightly anomalous. So if you don't have a rectal thermometer in your ambulance or in your gear, generally they're colored red instead of oral blue, then you wouldn't take a rectal temperature. But you should have a rectal temperature probe, and you should be able to take a core temperature. So if their core temperature is greater than 104 degrees Fahrenheit, or if they have altered mental status in the presence of hyperthermia, we're going to assume that this is heat stroke, and we're going to treat it as the medical emergency that it is. So we're going to cool this person by misting and fanning the skin. Truncal ice packs and wet towels and sheets may be used, but again, they're less effective. And then we're going to discontinue active cooling when the patient reaches a stable body temperature. And so the state of New Hampshire says that temperature is 101.5. What we do not want to see is shivering, because again, that will completely and entirely defeat the point of our cooling. All right, so this is the end of the chapter. There are a few other things included in this chapter, including bites and stings, altitude illness, and lightning injury, a sum total of about a page and a half. So review that information and let me know if you have any questions.